Hello, everyone. My name is Paola Klauser, and I am an Italian breast radiologist at the Medical University of Vienna in Austria. And in the next 15 minutes, I will share with you some of my experience in breast images, as well as some of my favorite places in Austria, as in this picture, for example, the hills and the vineyards just outside Vienna. We can start straight away with the first case, which is a 70-year-old woman with a negative family history for breast cancer, which complains about discomfort in the right breast since several weeks. She already underwent mammography, ultrasound, and MRI in another facility, and she came to us with all the images for a second opinion. If you see the mammography performed in another facility, it's obvious an asymmetry between the two breasts with a denser right breast. In the outside report, an asymmetry in the medial aspect of the breast was described here, but no correlate was found on ultrasound, and the mammography was reported at BI-RADS 0. If we look at the images, we can see also an additional architectural distortion associated with the asymmetry, better visible in the CC view, which actually quite annoying or quite suspicious. And we don't have previous imaging, so we cannot evaluate whether this asymmetry and this architectural distortion are something new or something that developed in the years or not. As the first imaging was inconclusive, the patients underwent afterwards MRI. What is striking from the MRI, already from the first post-contrast images, is a very strong asymmetry between the enhancement in the right breast and the enhancement in the left breast. This was described in the outside report as asymmetric background parenchymal enhancement, but the patient is 70 years old. The enhancement, especially in this medial part of the breast, is very strong and is as a plateau curve, which is not typical for background enhancement. It's heterogeneous, and some areas seem almost to show some spicules. The ADC is unspecific and does not help us very much, as often is for non-mass enhancements. We performed the second look ultrasound, and we identified in the medial aspect of the right breast an hypoechoic area, hypervascularized and with some microcyst as a correlate for the MRI finding. Also at the MRI, we identified another area of mass and non-mass enhancement on the left side in the lateral quadrants. Also here we see a partially spiculated mass, and also here the ADC is unspecific. In this case, we didn't find a correlate on ultrasound, but we were able to identify a small cluster of very subtle amorphous microcalcification, which was initially overlooked in mammography. I hope you can see it on your screen. I know it's very subtle, but it was there. And so we upgraded both breasts at BI-RADS 4, and we decided to perform a biopsy on both breasts. Of course, ultrasound on the right side, because the finding was obviously visible on ultrasound, and a stereotactic biopsy on the left side, as the lesion was obviously visible in mammography. We found on both sides a ductal carcinoma in situ grade 2. All to say that if a patient comes to you with symptoms, it's always important to carefully evaluate the whole imaging, not to miss subtle findings that can actually be something malignant. Also important to remember, DCIS does not always present with microcalcification, and it might be easier to see in MRI, but also the MRI findings are subtle, and if you are not used to them, you might misinterpret them or overlook them. We can move on to our next case. Patient number 2 is a 45-year-old woman. This was her first screening mammography that she underwent 1 hour before coming to our attention. You probably see the marker that the radiology put when he evaluated the first mammography, and he found a small cluster of microcalcification, also visible here in this particular, in the tomosynthesis. It was biopsy. The stereotactic guided biopsy found a ductal carcinoma in situ. The patient was operated, and she came to us the first time after 1 year for the first control. Here you can see the postoperative changes in the right breast, and what the radiologist described outside was this increasing architectural distortion in the central prepectoral aspect of the left breast. If we compare old images with the new images, we can see the post-operative changes on the right side with the scarring here. After radiation therapy, a bit of a skin thickening, but no new lesions and no new microcalcification, only some fat necrosis visible also on ultrasound. In the left breast, we actually see an increasing in an architectural distortion here, but the MLO view, was not performed correctly in the last mammography, so it's actually quite difficult to compare the findings. And if we see the baseline and the first control mammography, you see a bit maybe of an increasing density in this area, but there is no real difference between the two images. The patients also underwent tomosynthesis, which help us a bit to answer the important question, is this finding new? Was it already there? The tomosynthesis again confirms the presence of a bit of architectural distortion and increasing density in this area of the breast, also in the tomosynthesis, better visible in the MLO view. We didn't find any suspicious lesions on ultrasound, and so again we decided to clarify the case with MRI. MRI found a small spiculated lesion with suspicious enhancement and restricted diffusion in the central part of the left breast, which was associated, and you can see it here, with an architectural distortion with also a suspicious non-mass enhancement. At second look ultrasound, we were able to find this spiculated lesion. It was actually hyperechoic and hypervascularized, but probably because of its hyperechogenicity and inhomogeneity, it was difficult initially to find on ultrasound. I think all these lesions come into question as differential diagnosis for the MRI aspect, but of course, considering the fast changes in mammography, some malignant finding is likely. And actually at biopsy, we identified an invasive ductal carcinoma grade 2 with ductal carcinoma in situ. A careful comparison with previous imaging is always important, and it might help you overlook subtle findings or pay more attention to subtle new findings. Let's move on to our next case. It's a 45-year-old woman with a negative family history. She presents with pain and redness in the left breast. She was diagnosed with mastitis, which didn't improve after 2 weeks of antibiotic therapy. At the beginning of the evaluation, she performed tomosynthesis, and in tomosynthesis, we see a focal asymmetry here in the mediocaudal quadrant of the left breast, a little bit of skin thickening close to the nipple, but no obviously suspicious finding. After 2 weeks of antibiotic therapy, an ultrasound was performed in our facility, and you can see close to the nipple some fluid collection. The skin thickening is still there, and there are some hypoechoic solid lesions, highly hypervascularized. So the aspect is partially typical for an inflammatory change, but the solid parts and the high hypervascularization make it difficult to differentiate. We decided to perform MRI as we had an appointment available within a few days, and MRI showed a very extensive area of enhancement with also homogeneous enhancement of the skin. The enhancement is persistent but heterogeneous, and you see several areas of necrosis inside. In the necrotic areas, you can see in the T2 weighted sequences some fluid levels, which you can see also in the diffusion, and both the fluid and the tissue partially show a restricted diffusion. So actually the MRI findings are partially typical of benign lesions, so inflammation has this inflamed cyst, partially also suspicious as the restricted diffusion. We decided to perform biopsy, and the diagnosis was granulomatous mastitis. Granulomatous mastitis is a rather rare entity, but you actually might see some of them in your career. It can present with really suspicious imaging characteristics and also clinical characteristics. It does not respond to antibiotic therapy because it's an inflammatory disease and not an infectious disease as far as we know, but it's benign. And it is important to know that this diagnosis is compatible also with very suspicious findings on mammography, ultrasound, and MRI. We are moving to the next case. It's a 47-year-old woman. She has clinical symptoms and a CT suspicious for ovarian cancer, and she was sent to us only to exclude suspicious breast finding, which were not suspected based on the CT scan. These are her CT scan. As you can see, she has a CT in all abdomen, and you can see a solid and a partial solid, partial cystic mass at the ovaries. And this is her mammography. She doesn't have dense breast, and the only thing we can see in mammography is this focal asymmetry in the medial quadrant of the left breast. We also performed ultrasound and tomosynthesis. Tomosynthesis didn't identify any suspicious nodule or suspicious architectural distortion, and on ultrasound the area actually really seemed to be just normal parenchyma. She had no suspicious lymph node, and the examination was reported as negative. Would you have done the same? It's my question. Would you have asked for anything else? We didn't. The patient underwent laparoscopy, and the diagnosis was adenocarcinoma compatible with invasive lobular cancer and no ovarian cancer. So the gynecologist called us back, asked us, without telling her the histology, to reevaluate the mammography. We said again that for us the findings were not suspicious. Then he told us the histology, and we decided to go for MRI. MRI showed a persistent enhancement overall this focal parenchyma area, which per se does not look particularly suspicious, but inside of it, you see it easily in the early images. You see some very small mass lesions with a very strong enhancement that also present with restricted diffusion in the ADC map. We performed again a second look ultrasound, but we didn't find any obviously suspicious correlate for these small masses visible inside this parenchyma, and we decided to go for MRI guided biopsy because we were not sure whether this was all cancer or whether only these small lesions were cancer, where the all areas were cancer. And so we thought an MRI guided biopsy targeting the most enhancing parts was actually safer to figure out what this lesion was, and the final diagnosis was actually an invasive lobular carcinoma grade 2. Take-home point: invasive lobular carcinoma can be extremely difficult to identify and to diagnose. A comparison with previous images is very important, not only with the last years, but also with older mammographies and previous year to detect slow developing asymmetries. And very important, invasive lobular carcinoma can metastasize in the abdomen, can give atypical abdominal metastasis even without obvious lymph node or bone metastasis. So that was it. I hope you enjoyed my cases. And only a few things before I finish the presentation about breast imaging in Austria. Austria has a breast screening program only since, I think, 7 years, so it's quite recent, and many breast radiologists are actually still learning. All women can participate to this screening program starting from the year of 40, but they are actively invited only between 50 and 69 years. Screening is performed mostly with mammography, but also tomosynthesis can be used, and it's done every 2 years. Breast radiologists and only breast radiologists can perform an additional ultrasound after mammography or after tomosynthesis for patients with very dense breast. As you probably noticed from my cases, breast MRI is widely available in several facilities. There is also availability of MR-guided biopsy, and thus MRI is often used also beyond European guidelines if the breast radiologist consider it relevant. So thank you for following my presentation. I hope you enjoy it, and goodbye.
Greetings from Malaysia. I'm Evelyn Ho, a radiologist from Park City Medical Centre, Kuala Lumpur, a medium-sized private hospital in the community. Malaysia is in Southeast Asia, made up of West Malaysia, also called Peninsular Malaysia, and East Malaysia, made up of Sabah and Sarawak on the island of Borneo. I have nothing to disclose. The distribution of services in Malaysia varies because of the topography, as shown with mountainous central regions. Some interiors are only accessible by foot, taking days, especially in East Malaysia. Services are available in all major towns and cities, and particularly in Kuala Lumpur, the capital of Malaysia, where a full range of high-end facilities for cancer diagnosis and treatment exists. And our country needs more radiologists. Malaysia is famous for its durians, especially the Musang King. Park City is treating staff to durians and rambutans, a welcome relief for respite from COVID-19 fatigue. The pandemic has also increased awareness that Malaysia is the world's largest source of medical gloves, producing about 65% of the world's needs. Preparations for COVID-19 began in December 2019 after hearing of some unusual pneumonia in Wuhan, China. With past experience from SARS and a strong public health backbone, our Ministry of Health sprung into action. By the end of April, diagnostic lab, critical care bed, and number of ventilators had markedly increased. The MOH appealed to the many private hospitals to loan ventilators. My hospital were among those that responded to this appeal. COVID-19 reduced patient traffic from fear of the disease and also from strict movement control order, where the radius of travel allowed was only 10 kilometers. Police were involved for enforcement. Mammography utilization dropped 80% in the month of April at the height of the MCO. There has been gradual relaxation of the MCO from early May, and patient traffic has progressively increased. However, there are targeted enhanced MCOs in parts of the countries where the need arises. In this chart, we can see that the overall top cancer in Malaysia is breast cancer. Malaysia has a multicultural, multi-ethnic composition. Lifetime risk for breast cancers vary amongst the top 3 ethnic groups. Chinese more than Indians, more than Malays, although the latter makes up the majority ethnic group. The relatively lower overall lifetime risk from the National Cancer Registry 2012 to 2016 is thought to be due to underreporting, as reporting of new cases of cancer is a voluntary exercise. Ultrasound and mammograms form the mainstay of breast imaging investigations. We do not recommend ultrasound for screening, even in young patients, but it is the first investigation of choice for symptomatic women 35 years or younger, unless clinically suspicious. MRI is used judiciously because of availability, cost, and gadolinium concerns. MRI is present in many government and private centers, but breast MRI services, especially biopsy facilities, are relatively few. More centers are now switching to digital tomosynthesis. Contrast-enhanced mammograms has gained traction. These factors may keep MRI use low. However, the 2019 third edition of the Clinical Practice Guidelines for Management of Breast Cancer does recommend annual MRI and mammography for BRCA carriers in the 30 to 49-year age group. My true tales or case presentations reflect our success in opportunistic screening and our challenges. Despite being a middle-income country or an emerging developing economy as classified by the IMF and World Bank, resources are limited. Therefore, in these stories, you may find elements where the ideal standard of care is modified for reasons of availability, accessibility, cost, personal preferences, acceptability, and most times without impacting overall survival. The cases will also illustrate how ultrasound plays a vital role in a diagnostic workup. Ultrasounds in Malaysia are performed by radiologists with the exception of a few centers where sonographers are employed. Case 1 is a 55-year-old Malay lady who came for her annual screening on her own initiative because she has family history. Left mammograms are presented. Do you see any abnormality? Always ask for all mammograms to compare for developing asymmetry or some pattern change which could strike you. Naturally, you need the right side as well for comparison. The subtle architectural distortion on the standard mammograms are better demonstrated on the tomo views as a small speculated lesion at 9 o'clock posteriorly. What would you do? Go to mammo-guided biopsy straight away? Before we address that, let's look at what are the differentials for this lesion. Other than carcinoma, be aware that a radial scar, although typically described to have a loosened central region, sclerosing adenosis and fat necrosis are differentials. For completion, are added fibromatosis, which is a rare desmoid tumor that can appear just like what we see in this patient and tends to be posteriorly located. We use ultrasound to guide biopsy wherever possible, as it is faster and more comfortable, cheaper than mammogram-guided biopsy. Using the tomo image slice numbers and distance from the nipple as our coordinates, we were able to locate the just nearly 5 mm lesion. Ultrasound-guided biopsy was done, proved to be a cancer, and hook wire localization for surgery was done 2 days later. The final post-surgery diagnosis was tubular carcinoma, a rare subtype of invasive ductal cancer comprising 2% of IDCs. This is more common in elderly women, has excellent prognosis and less likelihood of lymph node spread. This year marks the 5th year of annual surveillance post-diagnosis. These mammograms are from routine screening for a 56-year-old Malay lady. I have highlighted the area of concern. Magnified views show coarse heterogeneous calcifications in a tight cluster. A nearby calcified vessel is seen. This finding was new compared with her last mammograms 5 years ago. Despite recommendations to do biennial mammograms, the onus is on the health-seeking initiative of the patient. This illustrates one of the features of opportunistic screening. In the approach to calcifications in the axillary tail, we should exclude skin calcifications, now easily done with tomo, artifacts from powder or deodorant application. Fat necrosis is a mimic of cancer, whilst in fibrocystic disease, the calcifications tend to be more dispersed and widespread. That leaves us with malignancy. Is it DCIS or IDC? I looked for the cluster on ultrasound, and knowing where to look makes it easier. I was able to locate a small lesion less than 1 centimeter with microcalcifications in the axillary tail of the right breast. Core biopsy was done, confirming a DCIS. Hook wire localization for white incision followed. The magnified specimen mammogram shows the characteristics of the calcifications better. She is currently well on tamoxifen in the 2nd year of surveillance. Opportunistic screening, as illustrated with both case 1 and 2 in our resource-limited setting, shows a cancer detection rate that is comparable to population-based screening in high-income Asian countries. As mentioned earlier, it is not a monitored or organized population-based screening program. Now we will move on to challenges. A 49-year-old Chinese lady presented with a left breast lump. The 2007 film screen mammogram shows a vague mass with anterior fibroglandular margin retraction in the left upper outer quadrant. The findings are no longer subtle in 2011's digital mammogram. There is an obvious spiculated mass, retraction of the skin, retraction of the adjacent fibroglandular tissue, and associated skin thickening. Note the few small round but dense left axillary nodes. There should be no doubt in your mind this is a BI-RADS 5 finding. The ultrasound series is not to the same magnification scale and is shown to illustrate her regular visits to our department. The ultrasounds were recommended by a Chinese medicine doctor, chosen for its safe profile and relatively lower cost, whilst mammography's radiation was deemed harmful. It was to review her response to the Chinese medication. We do not turn away patients even if they have rejected standard of care because it provides us with an opportunity to counsel and hear them out. In some cases, we do manage to change a patient's mind. You see a chest x-ray from 2011 when the patient finally considered surgery. The breast mass by then was very visible on the pre-op chest x-ray. The photo on the left from 2008 shows discoloration of the skin from applied herbs. Malaysia, being multi-ethnic and multicultural, brings a colorful array of presentations, as illustrated by photos of late presentation as young as 27 years and mammograms with history of having a lump from 5 to 30 years. Till today, we still see late presentations now and then in the urban areas. These factors can be grouped into 3 main categories of cultural tradition beliefs, fear and ignorance, logistics. I will highlight a few points other than those already illustrated in the recent case that I presented. Lack of autonomy may mean she may not be allowed to receive treatment. In Asia, men are still often head of household. Women in remote areas may never have heard of cancer. Asians are also generally very shy exposing their breasts, sometimes even to their female doctors. Logistics is a real issue. Who is going to look after their family when they go for treatment? So much so they would rather not go and get tested. How practical can it be if women need to track days to reach a treatment facility, even in a government hospital where the treatment is almost free of charge? Social media with dis and misinformation is a bane, not a boon, when it comes to breast cancer. For example, anti-mammo movement is going strong. The radiation, the pain, and the fact that compression may cause cancer to spread. In Malaysia, there is a slight preponderance of premenopausal cancers, where 61% of those diagnosed are under 54 years of age. In my practice, most of my breast cancer patients are from around 40s to early 50s. About 48% present at stage 3 and 4, and therefore it is not surprising that the mortality ratio for Malaysia is 0.39 compared to US of 0.15. Next, we will show you how we can be surprised by findings. A 48-year-old Indian lady came for routine screening. Based on these mammogram findings, would you do further imaging or be happy to call these benign? Bilateral, relatively symmetrically located, well-circumscribed masses, but why was it located posteriorly? So here are her before mammograms, and it is evident that the findings are iatrogenic. As we see a variety of injected augmentation, I was curious, what had been injected? The patient was also surprised that her augmentation had left a telltale sign after having been reassured by her aesthetic doctor that it would be resolved. A is the ultrasound panoramic image showing the main collection in the left breast simulating a subglandular implant about 10 centimeters in diameter. B and C shows more anterior cystic lesions, most with intracystic contents. The patient had hyaluronic acid Injection augmentation, a rare instance when the patient could tell me what had been injected, but she could not tell which type was injected. She did not do anything else to her breast since that episode, but her serial mammogram showed implants are growing, as if hygroscopic. I could not find any reports or info on this phenomena and would be delighted to hear from anyone with similar experience of such findings. Please contact me on email. In the meantime, she's quite happy with her full breast and has been advised to see a plastic surgeon. Injection augmentation always presents challenges as patients almost always never volunteer this information. It is usually a surprise on mammograms or ultrasound. The usual complaint will be lumps or sometimes painful lumpiness. Women can be of any age group from the late teens to older. Calcified granulomas and specifically siliconomas, as shown in the mammogram on the right, depending on the extent, makes it impossible to find cancers. The usefulness of mammograms therefore depends on the extent of breast tissue reaction, what, and the amount that was injected and whether it calcifies. In this patient, the mammogram is still useful. On the right are also images of free silicone injection on ultrasound, the spot diagnosis of snowstorm appearance or echogenic white noise. Silicone can migrate or seep to the axillary nodes as shown in the lower right image. My last breast imaging tale has a 15-year span. A 29-year-old Chinese lady had a left breast lump. Ultrasound was the first investigation of choice, as most young patients have either a lumpy texture but otherwise normal ultrasound scans. In this age group, benign lesions such as fibroadenomas or even cysts are far more common than cancers, and ultrasound is also far more acceptable. The most significant finding is presented. Is this a complex or a complicated cyst? Is that just some free mobile debris, or is it a mural nodule? Differentiation between a complex or complicated cyst is important, as it would avoid unnecessary biopsy or close follow-up. A complex cyst may have mural nodule or thick walls and septations, whilst a complicated cyst is basically a simple cyst but with contents which could be blood, pus, cholesterol, milk, or calcium. Small cysts, especially less than 10 millimeters, can be difficult to accurately characterize sometimes, so it helps if you know how to optimize the ultrasound settings and use elastography and Doppler, if you need to. These are her mammograms. What is your diagnosis? Very dense breast with some scattered cells on the right with a small cluster posteriorly. Left breast segmental coarse heterogeneous calcifications in more than one part of the breast with some fine calcifications. Findings are consistent with left multifocal DCIS or extensive DCIS, and on the right, a slightly suspicious cluster. The first surgeon she saw decided to perform an excision biopsy of the palpable complex cyst on concerns of tissue adequacy on core needle biopsy for histology as well as patient preference. Obviously, the histology resulted in the need for these mammograms. Both were surprised with biopsy results, which was IDC with DCIS. Would MRI be of any use at this stage? It would not add information to the left side, but perhaps the right. Today, there is the option of contrast-enhanced mammograms, a cheaper, faster evaluation. What about genetic counseling referral? For a 29-year-old about to lose a breast, this was a lot to take in even with reconstruction. The decision was then to do left mastect with recon, right 6-monthly mammo. Annual mammo would include the left side. These are the patient key timelines since initial diagnosis. Selected left MLO of her reconstructed breast is shown, highlighting a recurrence, group or large cluster of calcifications in the left reconstructed breast 2 years later. She eventually had bilateral cancers, did genetic testing, and after delivery of her son, underwent removal of the uterus and both ovaries. She is currently undergoing treatment for right IDC, only discovered this year. We continue to remain in contact despite her move overseas to follow her husband because of work reasons. The Angelina effect has increased awareness and interest in genetic testing even in Malaysia. We do see prophylactic mastectomies and oophorectomies now. Barriers to testing other than cost are marriageability, insurability, employability, and availability considerations. I'm happy to report that Cancer Research Malaysia, focused on Asian cancers, now offers genetic counseling for inherited predisposition for breast and ovarian cancers. This brings my tales from Malaysia to an end. On the right is a Wi-Fi of some of us in the Park City imaging team. Do visit beautiful Malaysia when the pandemic is over. I hope my photos can give you a glimpse of what Malaysia has to offer. Thank you very much for your attention.
Good afternoon, dear colleagues. Let me start by introducing myself. My name is Katerina Buськo and I'm breast radiologist from Russia. It's a big honor for me to take part in RSNA at this difficult time, and I hope that we will meet in offline format soon. The topic of my talk is multimodal approach of breast imaging. How does it work in Russia? The Russian Federation is the largest country in the world, population of 146 million people. There are many resources in Russia, such as oil, gas, forests, but the main resources are people and, of course, our beautiful women. I'm living in St. Petersburg, and in my opinion, it's the most beautiful city in Russia. St. Petersburg is the heart of Russian history, the northern capital, northern Palmyra, northern Venice, the city of white knights. It's hardly a complete list of unofficial names of St. Petersburg. What about the breast cancer screening in Russia? Russia belongs to countries without government screening support programs. Today's situation allows women 40-75 years old to get the preventive mammography. The examination is free for women who have government health insurance. Also, all women can visit private clinic and get mammogram, ultrasound, and MRI examination for a fee. The examination price is not so high and it's available to almost all social groups. Breast cancer is presented as the main cancer-related pathology among female population of Russia. It accounts about 21% among all female malignant tumors. The average age of patient with primary breast cancer in 2017 was 61 years old. Leading localization in the general structure of cancer mobility are: at first place, skin with melanoma, 14%, at second place, breast, 11%. What about diagnostic of breast cancer in Russia? Russian doctors have opportunity to make the choice between specialty of radiologist and the sonographer. And this poses the main problem, I think. Generally, the patient in Russia is examined by 3 doctors: radiologists who describe only mammogram, radiologists who describes only MRI, and the doctors who perform ultrasound investigation. Too narrow specialization does not allow the doctors to see the full image of breast cancer diagnostic, and it sometimes can be the reason of false positive and either false negative diagnosis. I work in National Medical Research Center for Oncology named after Nikolai Petrov. It's one of the biggest scientific treatment centers in Russia. Our center is one of the first in Russia which start to use multimodal approach to breast imaging. Breast radiologists check the mammography, MRI imaging, and in case of identifying the pathology, perform the ultrasound diagnostic with elastography and, if it's necessary, ultrasound-guided core biopsy. Now, let me turn to the presentation of clinical cases from my practice. Let's take a look at the case of 46-year-old woman with palpable lump of left breast. With the help of mammogram, the hyperdense lesion was found in the left breast. The lesion had round shape and inducing margin. This characteristic match the BI-RADS5 category. We also found the more suspicious lesion in mammogram, but only in one CC projection. The following step was multiparametric ultrasound. The lesion had hyperechoic structure and high vascularity on ultrasound. In addition, some words about differential diagnosis. Some lesions can have hyperechoic structures such as angiomyolipoma and hematoma. Also, invasive lobular carcinoma, sarcoma, but the benign lesion will not have high vascularity. That's why we gave it 5th category according to BI-RADS. Then we found the additional lesion in subarachnoid areolar area of the left breast. It was hypoechoic lesion with irregular shape and indistinct margin. This lesion had the classic ultrasound characteristic of breast cancer, but we could not find it with the mammogram. After using ultrasound, we detected one more lesion at the 3 o'clock position in the right breast, which also did not appear on the mammogram. Thus, we found the metastatic axillary lymph nodes. Ultrasound diagnosis is a bilateral breast cancer, multicentric in the left breast with the metastatic lymph nodes. According to the fact of detected additional focuses of breast cancer, the MRI was performed. The main lesion in the left breast had a clear circumscribed margin, heterogeneous contrast enhancement, and third type of kinetic curve. But using MRI, we found 3 more lesions in the left breast and 1 more lesion in the right. The final radiology diagnosis was a bilateral multicentric breast cancer and the metastatic left axillary lymph nodes. Unfortunately, the patient had the multiply bone metastasis, which was detected with CT. The ultrasound guide core biopsy of 2 lesions, the main lesion in the left breast and the lesion at the 3 o'clock position in the right breast, was performed. Core biopsy of the right breast showed classical type invasive lobar carcinoma. Core biopsy of the left breast showed pleomorphic type of invasive lobar carcinoma. Summary of this case. Clinical examination of mammogram has found only 1 lesion in the left breast. Multimodal approach, mammogram, ultrasound, MRI let us find much more lesion and assess the distribution of bilateral breast cancer. 2 core biopsies should be done in case of different imaging of 2 lesions in the left and in the right breast to be sure that it was one type of breast cancer. Pleomorphic type of ILC shows more pathologically aggressive feature than classical ILC. At this case, hyperechoic mass was pleomorphic ILC, hypoechoic mass was classical ILC. But according to the data taken from literature, pleomorphic type cannot be differentiated from classical type of ILC based only on imaging findings. The next case of 42-year-old woman with palpable lump at the left breast, no family history. On mammogram, equal density mass, irregular shape, indistinct margin, no calcification, BI-RADS-free category. Differential diagnosis between fibromatosis, sclerosing adenosis, DCIS, and ST carcinoma, and the next step is multiparametric ultrasound. On ultrasound, hypoechoic mass with microcyst, irregular shape, indistinct margin, with vessels in the rim and intermediate elasticity. BI-RADS-free category. The next step is MRI. On MRI, non-mass enhancement with focal distribution, heterogeneous internal pattern, second type kinetic curve. The MRI features can match DCIS, BI-RADS-4 category. Ultrasound-guided core biopsy showed sclerosis adenosis. As a result of radiopathological discordance, the surgical excision was elected. Final pass, DCIS, G2. Summary of this case. In case of radiopathologically discordance, it's very important to discuss it with MDT. The features match to DCIS. It is palpable lump, mass of mammogram, mass on ultrasound, and hypovascular lesion on color Doppler and MRI, and also contrast enhancement ultrasound. The last case of asymptomatic woman, 71 years old, no family history, previous ultrasound, no lesion, BI-RADS 1. On mammogram, high density mass, irregular oval shape, circumscribed margin, no calcification, BI-RADS 4 category. Next action is MRI. On MRI, hypervascular mass with homogeneous internal enhancement, BI-RADS 5 category. Next action is ultrasound guided core biopsy, but the mass was not clearly seen on ultrasound. It means no target for biopsy. But when we used elastography, we were able to find the target. It was isoechoic mass with force elastic score, strain ratio 10. It was a hard lesion. BI-RADS 5 category, and next action, ultrasound guided core biopsy, which was done. The result of the path was invasive mucinous carcinoma of the right breast, G2. A lumpectomy with scintillant lymph nodes biopsy was selected. Summary of this case: mucinous carcinoma can be occult on ultrasound B-mode. MRI is the most sensitive method to detect mucinous carcinoma. Ultrasound-guided core biopsy is a better and easier way to receive the histological sample. Ultrasound elastography let us find the target for the core biopsy. And of course, those clinical cases clearly demonstrate us how important it is to use multimodal approach in breast imaging. Finally, I want to say thank you to organizing committee and Jion Lee for inviting me to RSNA, because it's the best platform to share experience among specialists from all over the world. Thank you for attention. If you have any questions, feel free to ask.